So again, we go back to the objective. Given a patient with chest pain, the candidate will perform an initial assessment to determine the urgency of the presentation and the need for emergent management. So I have this question for you. You have a 48-year-old male who is brought into the ER with a history of chest pain. You would like to review possible causes. What are your initial assessment and management steps? So if you have a patient with chest pain, what are your initial steps, assessment and management? So you realize that this question is twofold. And so don't only look at assessment and don't only look at management. Will somebody want to raise the hand, unmute and engage me so that we can have a conversation about this particular case? Anyone at all? Anyone wants to?
We can just do like a first test exams.
So Dr. Nabi is saying we can do an e-fast. Okay.
Yeah.
Is that the first thing you want to do in a patient with chest pain?
So we will just take ECG first, and we will just check a physical examination. We will figure out how is the chest pain. So how it looks like. So we will just focus that it's going to be gastrical or it's going to be pulmonary. It's going to be like cardiac. So it's going to be blind trauma or something. It depends on the pain. So we'll figure out if it's going to be, then the life's going to be threatened. So directly we'll just refer the patient to the operating system.
Okay, sure. So that's a good try. Will anyone want to look at it from a different perspective as well?
Yeah, I will check the vitals first. Vitals, blood pressure, heart rate.
Sorry, Dr. Sumaka, I think your mic went off.
Sorry, yeah. So blood pressure, heart rate, respiratory rate, Glasgow scale. Then if patient is in shock or not, and then urine output maybe, and the ABCs I will do maintain the airway, breathing and circulation.
Okay. And then what else? But you jump to something else. So it's good. You did the vitals, you do the ABC.
Monitor.
You have to take like a detailed history.
Wait, before you even start the history, you have to put the patient on a cardiac monitor, right?
On cardiac
monitor first.
So let's go. So your initial assessment of a patient with chest pain, what are the steps? Number one, you want to assess the airway, the breathing and the circulation, the ABC. Boom. That is the first thing. Next line, you want to do a preliminary, like, hey, what happened? If the patient can speak to you, when did it start? While you are doing this, you are putting the patient on a cardiac monitor. And, you are doing these things concurrently. You are putting the patient on a cardiac monitor. You are getting your ECG because the patient comes in with chest pain within 10 minutes and ECG should be done, okay? You are making sure that you have your resuscitation equipment on the bedside because anything can happen. And then you also want to give oxygen if necessary. And this is very important because I've seen that some people would like to at times give oxygen blindly. No. Oxygen can give some form of oxidative stress to the cells. And if the patient is saturating around 93, 94%, you don't want to give oxygen unless the patient is around 88% and the patient does not have a history of COPD. But if the patient, is a regular run-of-the-mill patient, oxygen saturation around 95, 96%, don't give any intranasal oxygen. You can get your oxygen stuff ready in case the patient's oxygen drops, but don't be in a rush to just be giving oxygen randomly, okay? Then you also want to get your IV lines ready and make sure that while you are setting your IV lines, you take blood sample. And the blood sample, you're going to do some blood investigation, but one blood sample you don't want to miss is the troponin level, okay? And then in this same patient who has chest pain, you want to make sure that you've given some aspirin, and depending on how bad the chest pain is and what the ECG shows, you may or may not give nitrates. So this is your initial assessment: airway, breathing, circulation. I'm putting the patient on a cardiac monitor. I'm getting my crash cart. I'm getting my ECGs to put on the patient's chest. While doing that, the patient needing oxygen or not needing oxygen, I'm going to set IV lines. I'm going to set my IV lines, take my blood sample, and is the patient in shock or not in shock? If the patient is in shock and it's not cardiogenic shock and the patient can take some fluid, with that IV line I've set, I can give some fluid. I can then give my aspirin and my nitrates if there are no contraindications. Okay, good. So
I had a question, sir. So it's just talking about the patients that like chest pain having like this procedure are showing us like a cardiac person that having a cardiac problem. So if the patient is having chest pain like showing, but the main effect is like a gastritis, maybe it's going to be like pancreatitis. So we just follow this procedure, or no? First of all, we have to just find out what's the main point of the pain that's coming. Chest pain is coming
that's
from
why I'm saying that you need
pulmonary.
That's why I'm saying that you need to do a preliminary history. You need to do a preliminary history because that will guide you, and that's why we learned
First of all,
various.
First of all, we have to just figure out.
Yes, that's why we learned the various causes of chest pain and the systems the chest pain can come from: the cardiovascular system, the respiratory system, the GIT. At times, it's very obvious. The patient may be pointing to the epigastric region, right? That one, you may be careful with just giving things. But if the patient is actually saying, I'm having crashing chest pain, I'm struggling with this, then at times you may want to go ahead and give your aspirin, because if the patient eventually is found out to have peptic ulcer disease, that aspirin you are giving is not going to kill the patient. But if the patient has acute coronary syndrome and you delay your aspirin, you delay your management of acute coronary syndrome because you want to get everything before you manage the patient, you may land in trouble. So now, next question. You have a 48-year-old male who is brought to the ER with a history of chest pain. An ECG done reveals the image below. You would like to give a nitrate spray. Outline 4 contraindications. I know that commonly amongst us as candidates for this exam, one of the main things we know about nitrates and contraindications for nitrates is the patient who has taken phosphodiesterase inhibitor or a patient with inferior MI. But beyond inferior MI, beyond the fact that the patient has taken Viagra or Cialis, what are other contraindications for nitrates?
Hypertension.
What do you say?
Hypertension.
Hypertension, sure. We talked about that. Yeah, what else?
Pulmonary. I forgot the name.
Okay, sure. Maybe someone else can also try something. So hypertension, phosphodiesterase 2 inhibitor, inferior MI. What else?
Aortic stenosis.
Aortic stenosis. Beautiful. Beautiful. I'm glad that you brought that up. So the contraindications for nitrates, because remember you're preparing for a board exam, right? There are some things you need to know, like knowledge you need to have. So number 1, severe aortic stenosis, not just regular round-the-mill aortic stenosis, severe aortic stenosis. Number 2, hypertrophic cardiomyopathy. Number 3, suspected right ventricular infarction. Number 4, a patient with hypotension, a patient with marked bradycardia, a patient with marked tachycardia as well, and a patient who has recently used phosphodiesterase 5 inhibitor like Viagra for erectile dysfunction issues. So please, as I said, I know that the issue of phosphodiesterase 5 inhibitor use and hypotension and inferior MI are commonly known amongst us. But beyond the basics, beyond these 3, what are other reasons why you don't want to give nitrates to a patient? What are other reasons why you don't want to give nitrates to a patient? And these are some of them: severe aortic stenosis, hypertrophic cardiomyopathy, suspected right ventricular infarction, okay, hypotension, marked bradycardia, and marked tachycardia, as well as recent use of phosphodiesterase 5 inhibitor.